This lecture series is part of an ICSSR-IMPRESS funded project, mHealth Technologies for Gender Empowerment. We are very impressed with the overwhelming response for this lecture series. Today is the second lecture. There are more than 380 participants who have registered. Some of them have registered more than once. So we request them not to register more than once. Please attend. And if you attend more than 60% of the entire lecture series that we have planned, your certificate will be sent to you over email. So this event is also being streamed live on YouTube. We had said that we'll be beginning in a couple of minutes, so maybe people are still joining in. We don't see 100 plus number. So at the onset, we would like to remind ourselves about the background of this lecture series. When we were analyzing data for the project where Dr. Papia is a PI and trying to comprehend what are the underlying determinants of gender empowerment specifically, it clearly became evident that it is a, multiple involvements, multiple issues are there, and the process of empowerment is so linked with various aspects of what we call broadly development or lack of it. This word resonates in the ear when there is lack of it more than when it is there. As social scientists, we know that development is very context specific. I always use this book to discuss with my students, the book by T.K. Woman, where he has talked about the trajectory of development discourse. I'm not going to talk about it, but I just want to remind our junior colleagues here, that we cannot forget the way some of these yardsticks like secularism, socialism, feminism, human development, participatory approaches, and others have come and has made us think through them. So in order to develop more nuanced, rigorous, and as informed by seasoned, senior, esteemed scholars that we have today, we conceived the idea to organize a lecture series inviting eminent scholars from different disciplines. Last time we had Professor Sachidanand Sinha from CSRD JNU. Next week we are going to have Professor Deepak Kumar, again from JNU, history of science and technology and education. So we call it contemporary development debates because we acknowledge and would like to accommodate different standpoints of development that coexist today together, and how it can be further. As I said, last week our director was there, online, inaugurating the event, and Professor Sachitanand was speaking. He talked about the role of the state, very useful these days, problematize the market, and within it the citizens. So it was very nice. It is my pleasure today to be the linking dot or the moderator, as Papia calls me, for this amazing panel of scholars. Last week we didn't have moderators, but we realized that we need to have other scholars, emerging scholars especially, who can take the debate and the discussion further along or along that theme instead of getting vague on it. This is the weekend, and people are kind enough to join, and so we can take rigorous involvement in this. As I said, it's my pleasure. Today we have Professor Tulsi Patel as a key speaker. I was a student during my post-graduation. She's an amazing person and an amazing scholar. The two discussants here are Professor Muhammad Akram, or Akram Bhai as we know him, and Professor Ajailu Numai. The inaugural note will be by Professor Indira. Let me just say a bit about Professor Indira. Um, she is a professor of sociology and former president of the Indian Sociological Society. She has been the president of Karnataka Sociological Association as well. She has held many academic and administrative positions of distinctions: Dean of Arts at Mysore University, Director of the Center for Women Studies. She has been in the governing council of the Madras Institute of Development, numerous awards and honors, Fulbright to Purdue, CEDA, which is the Canadian International Development Agency grant, and Indo-Sastri to University of Calgary. Not sure if you know that her work in the Joida region of Uttara Kannada district in Karnataka has been hailed as a piece of research that set the stage for many changes in the forest region, which remained virtually out of contact with the world at large, but not now because of her work. A proactive teacher, she has blended academics with activism and has lectured and written extensively on gender and related issues. Her books and articles on research methods, culture, gender, empowerment is guiding the next generation of scholars. Let us now listen to Professor Indira in what we call an inaugural note. Over to you, ma'am.
Thank you, Dr. Aditya. Good evening to all of you and Professor Tulsi Patel, Professor Akram, Professor Rajailu, Dr. Aditya, Dr. Papia, all my colleagues and student friends. Well, I thank you for this opportunity. And when I must say that you know, it's a matter of great pleasure for me to be part of this event, and it was very kind of you to give me the opportunity to be part because it just came from a meeting in RC10, a lecture program by Professor Rajesh Gill. And so I'm overwhelmed by your kindness, and it's a great pleasure to meet and listen to Professor Tulsi Patel and meet my colleagues, Dr. Akram. Ajalu, yes, we have been meeting more often, but it's always a pleasure to listen to her and to all of you. Well, when Patel, Professor Tulsi Patel is talking about health, gender, development, I have nothing to say. I have come here, ma'am, to listen to you and to learn from you. But all I just want to say is that, if I have tried to understand and interpret development, it's always an emerging issue and a concept and a practice. Well, I think that whole issue of development needs to be revisited, and we have to keep on reviewing what has been achieved, what has not been achieved, what has been wrongly done, and still the gaps that are remaining in that whole discourse as well as development activism, as I call it. And in fact, there is a history to this whole discourse on gender and development. I would remember that when I went for the interview for the professorship, one of the senior professors from Karnataka who was in the board asked me this question. He said, "What are you talking of gender and development? Let me know whether there is a separate development for men and women." He said, "You convinced me by your answer." Of course, I had thought about it earlier, so I explained. He said, "Okay, now I am convinced," because I always wondered why you people there, especially you feminists, are trying to make out, bring this gender into everything. You say feminization of poverty, then you look at health, and then he was asking me, "Do you think there is a separate fever for men and separate fever for women?" I said, "No, sir, fever is fever, I agree. But then the way people respond and the way the body responds and the care system that is in place, these are the things that need to be looked at from a gender."
As important as maybe or relatively speaking, class, rural urban divide, minority status, marginalized poor people, whether they are in the urban areas or in rural areas. Now, given this kind of disparity in the country, how does the role of empowering come into being in the health sector? Health sector is certainly unequal. We have WHO has estimated that by 2013 by 2030, which means 9 years from now, there will be a shortage of 18 million health workers in India. So the difficulty of being able to find health workers is going to increase, and we'll see that this is becoming a more acute problem. There are only zero point 0.7 doctors for every 1,000 population in India, 1.3 nurses for 1,000 population, and 1.1 beds per 1,000 population. I don't even need to say all this given the context the last 2 years of COVID-19 that newspapers and media has flooded us with information about how tough it is to get access to health when there is a crisis of that kind. But even in general, a 0.7%, 0.7 doctors per thousand population is far, far dis- disproportionate if we talk of equitable health. And the difficulty further increases when we see 17% of the world's population is in India and the global burden of disease is 22%. So we are disproportionately diseased in comparison to many other countries. And unfortunately, 30% of the population every year goes below poverty line due to the increasing health expenses. Health facilities and health infrastructure, health machinery technology has increased. But alongside that increase, what we find is that there is a rising cost to it. The expectations of patients are different. They expect better health. And while there are expectations and some facilities available, the cost is rising. And disproportionately, we have 70% of the health infrastructure located in 20% of the cities. So the rural urban divide in terms of health facilities is very, very strikingly unequal. Now, in this context, when there is so much of inequality, how does one get empowered? And what does it mean for people who can afford it, who have access to infrastructure and can pay for the cost, and those who cannot? Where does the idea of empowerment contribute in this context? And in this, in this frame of health structure, we also see how the course of development, particularly since the Second World War, has been a course where control of nature by man is something which has been the primary target. That has been the principle of how development has evolved all over the world. And this idea of a modern society, which can, where man is in greater power over nature, whatever you can extract from nature is makes you more powerful. Industrial development, technological development, all other kinds of development that the development path in general has taken over the all over the globe has been in one direction, and that direction has exploited nature. After the COVID-19 time, last 2 years, and much before 1945 onwards, this development began, and by 20 years' time, there were some new social movements which began to protest against the kind of development because this was unequal. Whether these were protests by women in the second wave of feminism or protests by ecology, by people concerned with the environment, both men and women, or concerned with large industrial projects or large dams, and this continued. So development by exploiting nature, on the one hand, was happening. At the same time, what was happening was a criticism of this development, a critique of the development. And we know scenarios where outside the United Nations, there would be protests by various NGOs and civil society organizations against some developmental plans that would be discussed there. So both these criticism and the manner in which development was planned went on continuously, and even today we have this. Now, the Wuhan virus, we do not know whether it came out of a lab or it came out of the zoonotical diseases, which are happening more out of man taking the place for wildlife. So wildlife, which was away from man, is now feeling that man is coming closer and trespassing their area. And we do not know whether infections are coming from bats or they are coming from labs. It's becoming difficult. So today, the critique against development of this kind is not something that we need to very much stress upon. All of us are aware. Last 2 years we have been hearing and reading about this criticism against this form of development. This is happening along with climate change. Now, various international agencies and countries coming together. So it's not only diseases but also climate change. Along with this kind of context, where on the one hand we have the Indian disparity, on the other hand we have the development and the discourse around development, which talks about the criticism of the kind of developmental path that we have taken. The idea of an epidemiological transition, which Omran talked about, that countries will go through a certain kind of shift from infectious and communicable diseases to chronic diseases, which happened for a long time, and the West would be understood.
क्योंकि ये ऐसे है ये इंक्रिप्शन और डिक्रिप्शन कुछ प्रोसेसिंग होती है कंप्यूटर में, तो इसी प्रोसेसिंग में जो
Please mute yourself.
देगा ऐसे सब खोलो काम देगा वो, तो इससे क्या आपके सीपीयू जल्दी खराब होने के चांसेस हैं। जो लोग इसमें जुड़ते जाएंगे उनका थोड़ा थोड़ा भाई काम बढ़ना शुरू हो जाएगा। प्रोसेसिंग यहाँ इनके
Okay.
Sorry for the inconvenience, ma'am. Please, sir.
Some parallel disturbance going on.
Yes. Please, sir.
So Omran's thesis of epidemiological transition is something that stood for a long time, where society moved from communicable diseases to chronic diseases or non-communicable diseases. But India was still a difficult country in terms of Omran's thesis because there was a double burden of disease in India. Both chronic as well as infectious diseases were going on. Lifestyle changes, increase in life expectancy, over 75 years of age today compared to 26 when in 1921 to 31 decade. This increase in life expectancy and chronic diseases would go together, old age diseases, but at the same time, infectious diseases continued. Today, after the COVID-19, the entire world is affected by infectious diseases as well as chronic diseases. And Italy is the illustrious first example of what happened in the Western countries where health facilities were good. So, both in terms of epidemiological transition as well as unequal distribution of resources in health sector, make India a very difficult place to think of providing health to all. In this context of severe shortage of health provision facilities, it makes good logic to have mHealth. mHealth is, as we all know, mobile health or telemedicine. It also includes all IT-enabled management and care of health. So, prescription as well as care is included under mHealth. So, there's a range of things which you can include under mHealth. That's the encompassing idea of mobile health. And the ratio of medical facilities and medical professionals to population also makes very good economic logic to have mHealth, where you do not, in terms of cost, in terms of time, in terms of outreach, it is possible to do far more health service than is possible for people to do in-person health service provision. So IT-enabled health is actually appearing like a boom. And in the COVID context, it was not just a boom, it became a necessity. Because if you had comorbidities or if you were in a certain age and the odds were against you, it was important that you stayed at home and got advice from doctors rather than go to hospitals. Excuse me. But much before COVID, the idea of empowerment in health and mHealth had emerged in India. The National Health Mission tells us from 2005, the two subdivisions of the National Health Mission, the National Rural Health Mission and the National Urban Health Mission, were two divisions that looked after the urban health sector and the rural health sector. In the rural health sector, particularly, ASHAs were introduced along with Anganwadi workers who were there in the past, CSDS programs, etc., ICDS programs, village level health workers, etc. There were these in the rural areas, but in addition to this, ASHAs were also introduced, accredited social health workers. Now, assistants rather. These ashas became important in terms of empowerment. Women, they were given a short training and employed in the community they came from, and they were to deal with people in the community about their health. They were the point of contact between people and health facilities. So that became easier for people who were not reaching or unable to reach health facilities. In 2005, the National Health Mission had identified 18 weak states in terms of poor health. And they were called the empowered states. Northeast states and Himachal and Jammu and Kashmir were added to it. So this was the weaker part of India, as it were, in terms of health. And these were empowered. Empowered means there were programs, especially programs in health for these states, both in their urban areas as well as rural areas. So National Rural Health Mission as well as National Urban Health Mission were steered to provide health care. All through the health policies in India, as well as the health budgets in India, if you look at that, the health expenses on family planning program have been rising consistently, whether it was before 1994 or after 1994, the ICPD in Egypt, Cairo ICPD. The focus on rural health mission by the ASHAs was also on the mother and child's health. There's an element of HIV and TB also included in the work that ASHAs are supposed to be doing. But the primary job was to be the intermediary between mothers and children and health facilities to get institutional deliveries. So the targets were set for institutional deliveries, and certainly from less than 20% to 56% within the first 10 years was a big jump for institutional deliveries that ASHAs managed to raise those percentages. In addition, infant mortality did come down. The only concern which remains today is neonatal mortality, which has not yet come down as expected. Now, information, education, communication are critical elements in any health service. Wherever you provide health service, there has to be communication. Even in Western countries, there are translators who actually translate between people who do not speak that country's language to enable the communication between health providers and health seekers. For all the information, education, communication in health, it is important to talk of a common language. India officially has 22 languages and unofficially thousands of dialects. If we look at the manner in which mHealth is to be operated, there are 165,000 apps that mHealth can work with. Excuse me. These apps one needs to know about, use them, or get trained to use them. And it's not only the doctors who need to be trained to use them, other health staff needs to be trained to use them. There needs to be somebody who will train the doctors and other staff, even if it is a very short training. But you need to familiarize yourself in order to provide information, education, and communicate it. Now, this kind of information, education, communication was to be programmed under mHealth. So mHealth is not automatically empowering. mHealth needs this kind of additional infrastructure or additional inputs. And it does not stop here because apps keep changing and new apps keep coming, which are updated or have a better nuanced position in terms of usage and advantage in use. So you need to actually, just as you move from one system to another, Android and iOS, and you learn new things, the new model comes and you learn something new in that. So constant refresher courses for short-term training for health workers as well as for the health seekers are required. So we are talking of a large infrastructure and a large investment which would go into mHealth to make mHealth possible so that access, outreach, time, cost, all these things can be saved through mHealth rather than person to person kind of contact, which has been the conventional contact. And interestingly, allopathic system of medicine, unlike Ayurvedic and Unani, which allowed indirect interaction between the physician and the patient. The allopathic system actually depended on the nosology. It evolved out of an objective, empirical looking at, observation of the body and communication. So from there, mHealth is taking us away where you have a medium, a virtual medium, which would be the intermediary between you and the patient or the patient's family. In the Indian context, the patient is generally not alone. It is the family as well. So the important thing is to be able to train the health seekers as well as health providers, and both in terms of a range of health seekers by age, disease, chronic, acute, etc., and also a range of health providers. So there needs to be a constant industry of training and refreshing of the capability. So while it is empowering, that information, that capability to be able to operate the algorithms, it's equally important that somebody who can train you for that is also present to enable you to do that. And that makes it more egalitarian, or that makes more sense if mHealth is to be considered as important. And it is important. For instance, for research, when now because of COVID and the possibility of these algorithms to be able to conduct research, a great deal of research is happening in the field of medicine and health through mobile technology. And in this, ASHAs as well as many other field investigators from social sciences and medical sciences are involved in collecting field information. One of the examples I know of is in autopsies. So collecting autopsy data from the field based on a certain number of pre-decided questions without any eye contact or ability to see the body language, but just on virtual communication. The investigators jot down data provided by people in the field for as important or as difficult an experience as death of a family member. And these investigators have to decide on the basis of 5 or 10 minutes of conversation across telephone or something, the cause of death. It's a very difficult kind of research to do through mobile technology, unless the person who is conducting the questions or conducting the questionnaire is herself or himself a competent doctor who has done autopsy, autopsy research or has experience of conducting autopsies. So, while this is happening at a large scale and it would help health improvement, because all research in medicine usually goes to enable more healthcare or better healthcare. Given that assumption, if this is the kind of difficulty in collecting data through mHealth or through IT technology, we need to be a little cautious about how it happens. Now, with 22 languages and communication, not just for autopsy collection, but for any disease discussion, it is not very easy because language is a problem, but so equally important is the medical culture. It has been found that are not interested in mHealth. Most of the public hospitals are terribly overcrowded, not just due to COVID, but even otherwise, they are terribly, terribly overcrowded. The doctors do not have time to actually spend with patients. They would rather use their use their knowledge, look at the patient, ask a few questions, and prescribe medication or these days more and more of tests. But one needs to keep in mind that the doctors themselves are overworked and overstretched. In this context, to think of doctors going for training, even if it is a half-day training, even in the private sector where doctors are working in their own clinics, it has been found that doctors do not want to go for further educational programs because it means cutting down on their day's work, missing their appointments with patients, etc. Now this cuts into the private service, and in the public service, it is because of overcrowding. To think of doctors taking leave and going for a training program to use these apps, even if it is 2 hours of the OPD, it can mean maybe 200 patients will not be seen that day. So we need to keep this in mind. This is a big challenge for using mHealth. These big challenges are there, but for a large number of people, and increasingly so, chronic disease patients need to be sent reminders, they need to be sent alerts, they need to be educated, informed about what they should be doing and what they should not be doing. And this is not only for chronic patients, but in the Indian experience, whether it is pregnancy yojana scheme or mobile kilkari or beti bachao beti padhao or janni suraksha yojana, all these plans also have expectations of ashas to be sending reminders, to be sending alerts, and enabling institutional deliveries in order to reduce maternal mortality, infant mortality, which is important for the health of a nation and the family, of course. So, keeping these things in mind, how do we look at mHealth as a great possibility on the one hand, but a great challenge on the other? And both these things go together when it comes to the kind of facilities mHealth provides, the kind of potential that mHealth has. And against this potential, we have very big challenges. These challenges also operate at the level of social inequality in terms of gender. For all the maternal and child health programs, maybe women would be approached by ashas and not a problem. But for other diseases, what are the possibilities of women being available for listening to alerts. Education, which happened online during COVID time, has given us a lot of data on a disproportionate possession of smartphones in India. People have sold their sources of livelihood to get smartphones for their children in school. Some people have sold assets, land, or some other asset to be able to get a smartphone for their children. And while mobile ownership has increased in India, it has reached 1 billion already. But there are multiple phones that people own, and that makes the average like 1 billion. But there are thousands and thousands of people in India who do not have smartphones, or they do not even have mobile phones, let alone smartphones, for themselves or their children. Sometimes families have a phone, but the woman does not have the phone with her. She does not have access to the phone. So, alerts and reminders for women's health and for children's health is a cause for concern. One needs to look at that issue as well. Disproportionate or unequal relations in health are not simply gender biased, but class in terms of ownership of mobile telephony, in terms of smartphones, caste, income inequalities are all important dimensions that we must consider in terms of how mobile health will be dealt with. I again would like to harp on the fever example that Professor India gave. So while a problem, a disease would be a disease which both men and women have. But if women are not able to have access to the family telephone, and it's most of the time with the man, and the man is away from home, she gets time only in the morning and evening. How do you expect ashas to be working? The place where I live, in a nearby village, I expected ashas to be able to tell me something about the village women. And I was told that these women, most of these women from the village, early morning leave the village in hordes. They come back in the afternoon, take a small siesta, and again leave later in the afternoon and come back. They are all domestic workers. So, in a poor village, which I was hoping to be able to talk to ashas and get some idea of how people from the poorer backgrounds are served by ASHA workers, was a disappointment because these women are not available. And when they come back home for siesta, they are so tired, they have to also do some work at home with their children in the family. So while they have telephones, they may not be able to use the telephones for health purposes. It may not be that valuable for them. For them, it is more important to be able to earn the money. That is a concern where you think of your daily survival, your daily wage as against this. And yet, I think that the potential for mHealth lies very much there. Because even if the alert can be heard, even if the reminder can be heard once a day or once a month, it is worth it rather than not having that reminder at all. So, while there are these kinds of inequalities, it's important to look at the role of the state as to how the state is performing in terms of mHealth. The weaker states have been able to have higher institutional delivery, better infant mortality rates. But at the same time, in the larger frame of the Indian context, what is happening is the public health is taking a hit. The percentage of GDP spent on public health is not increasing, rather, it is decreasing. While population is increasing, the cost of health is increasing, the percentage of GDP for public health is on the decline. Privatization, rather corporatization of hospitals is increasing. And very often the logic that the state provides is that by providing health insurance schemes, Rashtriya Bima Yojana or Pradhan Mantri Bima Yojana. By providing these schemes, it is possible to provide greater health. You say, oh, this is the percentage of the health budget which goes into health insurance. And the research that is being done by people like Punendu and others in the area of health insurance in India is a big question on ethics. It's a big question on ethics because I think India is the only country where hysterectomy at a very young age for a mass number of women is performed because there is insurance. I know of cases where Ayurvedic and Unani doctors, as part of Ayush program, have conducted cesarean sections on women, even if only allopathic doctors are supposed to be conducting those. But if an Ayush position is occupied by an Ayurvedic doctor or a Unani doctor or a homeopathic doctor and they operate, it's a very serious ethical issue. So while on the one hand there are these problems of the economic disparities, social disparities, cultural disparities. There is also a serious problem of ethical issues where profit making, the shift from health as a service, Florence Nightingale onwards, against health as a commodity which is being sold for profit. The very logic of privatization of health needs to be questioned. And how do we operate? It might be very easy for private healthcare providers to justify mHealth, to look at the potential. We are not disregarding the potential, but in some way, we need to be ethically more aware. And that kind of awareness also should become part of the empowerment program for health workers. Otherwise, it might be some information, some capability of operating algorithms for personal empowerment, it might be useful. But for the society as a whole, how does one see this? And the overload that medical professionals in public health have, it is expecting too much of these doctors to be able to jot down all data digitally for patients. Much of that data might not even be clinically useful. And it is said that a greater burnout in US, a greater doctor burnout in US is happening because there's a lot of this extra work which becomes part of digital health provision. So these are some of the issues that I wanted to raise in terms of empowerment, as particularly for gender, but certainly for class, rural, caste, class, rural, urban divide, poor, rich divide, and the public-private divide. So it is these kinds of inequalities within which we need to look at how development is progressing, how development in health is progressing, and what are the challenges that health and disease are actually being encountered, and how do we look at the potential of mHealth and the possibilities that it can provide. Thank you.
Thank you so much, ma'am. Thank you so much for bringing in the opportunities through mHealth and the challenges that it has. A couple of questions were there which you've already covered, and there are few we will talk about. But here I would like to bring in the two discussants, our emerging scholars, our senior colleagues, Professor Muhammad Akram and Professor Ajelu Numai.
Yes.
They are there. Just I'll give a brief introduction to both of them. Um, Muhammad Akram is a professor at Aligarh Muslim University. He has published numerous books and has been publishing on health, sanitation, maternal health, dynamics of health and marginalized. He has presented and chaired in various forums, supervised students, is there with Indian Sociological Society, with RC12. He was there, and then as a member of the managing committee. Personally, I'm very impressed by the way he spearheaded. Maybe all of you know, he spearheaded the relaunch of Bihar Sociological Society. Akram Bhai, this may be one among your many contributions, but this region, Bihar, and all people here doing sociology will remember you for ages. So that was about you. And my senior colleague from JNU, Ajay, is the head of the Center for the Study of Social Exclusions and Inclusive Policy at the University of Hyderabad, a PhD from JNU, UGC Raman Fellow for postdoc at University of Iowa. She's really inclusive in her research and lived experiences. She has researched and published on children, civil rights, disaster and relief, empowerment. Some of her publications that she shares with us over WhatsApp are all wow moments. She has also been involved with the Indian Sociological Society in RC4 and management committee. And from the time I know her in JNU, she has been the guiding light for us. So I'll stop here now and we will go to these two discussions, Professor Akram and Professor Ajay. Maybe Professor Akram can first take on and then Professor Ajay will come in. Thank you very much. Professor Akram.
Uh, Thank you very much, Dr. Aditya, Dr. Papia, and IIT Patna for giving me this opportunity. And thank you, Dr. Aditya Raj, for making that a fantastic introduction. I loved it. Right. So basically, when you are talking about Bihar Sociological Society, then that has also served my purpose. Because, see, development is contextual. We started talking about development almost 100 years back in a formal way, although we started with the idea of planned change. But ultimately, we all realize that development is contextual. Professor Tulsi Patel, ma'am, very elaborately, lucidly, coherently, and inclusively identified all the possible dimensions of development, empowerment, and mHealth. I find it very difficult to make any intervention in whatever she has said. But Dr. Aditya has given me a point, bringing the contextual issues basically. When we talk about all these issues, then certainly when we go by a national narrative or a central narrative, then we find that the things can be seen or examined in a very coherent way. But getting guided by the core idea of development, this is contextual, this is relative. And when Professor Tulsi Patel was highlighting the issues related to inequality and disparity, then we all are aware of the fact that if we look at it from the perspective of health, then in India, all the states vary in terms of development index, in terms of health index. We have states like Kerala and we have states like Bihar and Uttar Pradesh, right? So there are huge differences and disparities. One of the biggest challenge that mHealth is going to have is how to address these issues related to disparities. Because on the one side, we have the Kerala model, and we can have several success stories. But at the same time, we are having the stories where we can say that we have not achieved the kind of success that we are supposed to, or where so many development agencies are working, but somehow the structural hurdles are creating so many obstacles that we are unable to. Because when we talk about mHealth, mobile health, then issues related to literacy and education will come. Then some kind of other types of disparities, the caste, the regional, the ethnic will come into force. And the issue is this, the how to address these things. So I think that Dr. Papia and Dr. Aditya Raj have taken up very serious challenges when they have basically started to work on issues like this. Then we can keep on talking about these things, but I don't think the time will allow us to get into the details of these things. So I've suggested few things that basically we need to identify. Then there are 2-3 other points. Professor Tulsi Patel ma'am was talking about mHealth and the kind of infrastructure support that is required. But we all are aware of the National Health Policy 2017, and the way this policy has dealt with the state support to the health programs. Basically, in 2003, the health policy of 2003 has mentioned it categorically that we need to increase the state's contribution towards health from 2% to 6%. But what is the situation as of now? The National Health Policy 2017 categorically says that we need to increase the health expenditure from 1.15% to 2.5% by 2025. That means we have already accepted it that now this is not going to increase. It is not going to even comparable to the experiences of the developed countries. Now, in a country like India, when we have so many health issues, and the COVID-19 has already made the things worsen, can we think of making the kind of improvement that we need to make? Without the state support. This meager state support is very problematic. Very often we talk about Kerala model, but perhaps we forget the fact that Kerala is giving highest per capita expenditure on health, whether that is in the state category or that is in the private category or that is the out-of-pocket expenditure. So some kind of expenditure on health is very essential, whether that is in the form of out-of-pocket or it is in the form of government. The universal health coverage model that we are following, that theoretically says that it is going to somehow address the issues related to the high out-of-pocket expenditure. But as Patel ma'am was talking about, the insurance model that basically we are actualizing, that is unable to address even theoretically. Forget about what is happening at practical level, but even theoretically, that is not going to be possible. Then two other points I would like to talk about basically here. I would like to raise these two important points. One is going back to the Alma Ata Declaration of WHO 1978. Very categorically, it was stated that health for all by 2000, we failed in that globally, very miserably. But I am not interested in talking about that. I'm interested in talking about the notion of primary health care. WHO in Alma Ata Declaration has very elaborately identified the notion of primary health care. But to what extent we are following the idea of primary health care? The way we are following the notion of primary health centers or primary health in India, or rather in most of the even developed countries, is far away from the prescriptions of WHO. Because primary health care is talking about a comprehensive care at the level of the individual within the family. This COVID-19 has actually exposed us that what kind of departure we have already made from the idea of primary health care. The excessive dependence on the medicalized kind of health care is actually some way responsible for causation of that kind of situation. Everybody is realizing as of today that the homemade kara are very important. Yes, we all know that the nutrition is the most important thing. But have you ever noticed what the NFHS data talk about the nutrition thing? The National Family Health Survey data related to the health of the children categorically says that there is huge inadequacy in terms of nutrition even among the children. On the one side, we have the highest number of stunted and wasted children and underweight children. And on the other side, we have huge inadequacy in terms of the basic nutrition provided to the children. So what kind of health programs we are having for providing some kind of nutrition for the children, and how the idea of mHealth can help? Of course, it can create some kind of awareness, some kind of knowledge, at least for the middle class people. At least they can understand the idea of nutrition, the micronutrients and the macronutrients. I don't know how many participants who are here in this program itself are aware of the kind of macronutrients that we need or the micronutrient that we need. So basically, the whole idea of health has moved away from the notion of nutrition to the nutrition of medical care. And that is actually, this is here, we need a kind of course correction. We need to go back to the core understanding of health, core understanding of nutrition. And one more thing I would like to talk about. One of my research students, Nadia Muzaffar, has worked on institutional delivery and cesarean section delivery in Kashmir. And that paper is published in Economic and Political Weekly. And this is one of the fantastic paper. We have written in this paper in EPW that there is an increase in cesarean section delivery along with institutional delivery. And this cesarean section delivery basically is somehow putting a question mark on the idea of empowerment of women. Now I'm coming back to the issue of gender and empowerment of women. Now, when we are, as a sociologist or as an academic community, not in a position to challenge the issues related to mindless growth of cesarean section delivery, we are not saying mega narratives on these issues, then where do we stand as of today? Basically, this is something that we need some kind of self-examination also. So there are so many issues, and I think that if we have this type of exercises where basically people who have some kind of empirical understanding, and when we have people like Professor Indra Rama Rao and Tulsi Patel who are having in-depth experiences, then perhaps we may move few steps forward in the right direction so that we can address these issues and somehow identify and devise some practical solutions to address this problem. This is all that I would like to say as of now, and given an opportunity, I would like to respond to these things further. So back to you, Dr. Aditya. Thank you.
Thank you. Thank you, Akram Bhai. Now, Professor Ajaylu,
Yeah, okay.
it's your turn.
Thank you, Dr. Aditya and Dr. Papia, for giving me this opportunity to be a discussion for this wonderful, thought-provocative lecture by Professor Tulsi Patel, and also the introductory remark by Professor Indra Ramarao. Already, Professor Akram has, I think, touched upon all the major points. So that leaves me with very few points to mention. I would first of all say that I thoroughly enjoyed Professor Indra's introduction, which is inspiring and wonderful, and also made a valid point that fever is fever, but fever affects men and women differently, which is so true. But I never thought that earlier in my mind until ma'am just made that comment in her introductory remark. Regarding Professor Tulsi Patel's lecture, I strongly feel that she has, touched upon the idea of empowerment in health and gender in this age of digital divide in a way that a lot of us would start asking questions as to how our health systems are inadequate and skewed in different states. She also mentioned some of the issues as to how Northeast or Jammu and Kashmir are still a weak state, even in terms of healthcare. Now, there are a lot of potential for mobile health, after listening to ma'am. For example, I want to cite the example of my own father, who is in Imphal in Manipur. And because of COVID, he couldn't come down to Hyderabad. He is a brain tumor patient and also have high blood pressure and diabetes. Now, his high blood pressure shoot up to 500 plus, and we are really helpless, because he doesn't have, he haven't even taken the vaccination, COVID vaccination. So what we did was that he could consult his doctor, and the chronologies here in Hyderabad due to mobile health. So mobile health has lot of potential and need to develop further. However, as ma'am also said, rural people most of them could not have access to the mobile health till today. And most importantly, the marginalized, excluded women are deprived of even having the smartphone, as ma'am clearly mentioned. And it's important to look into the role of the state when there is a privatization of health that is proliferating across the country. In fact, after listening to ma'am, it reminded me of the second wave of COVID, because during that time, we've seen how our colleagues, our dear and loved ones also were badly affected. I mean, including many of us. We saw and we witnessed how beds are not available in the hospital. Oxygen cylinders were not available and sold in the black market for prices ranging from 50,000 to few lakhs. And medications were not available, to everyone. It was sold in the black market, and it was sold at skyrocketing prices. Now, this made us realize that government of India should invest more in the healthcare rather than on the military and nuclear weapons. The worrisome current statistics reveals that, in the context of marginalized people, particularly on the Adivasis who are in the inaccessible areas and in the remote hill areas, around 104 million Adivasi people in India live as the poorest of the poor, besides the Dalits and other minorities. And almost every second family suffers from food insecurity. And it means malnourishment, which Professor Akram also mentioned about, Now, malnourishment due to low calorie, below the recommended dietary allowances. The nutrition expert estimates that the nutrition experts estimate that an average consumption of each meal should be 1,500 calories per day. But then a huge number of these marginalized families could barely survive and enjoy square meals a day. Forget about building immunity with protein diet during the second, particularly during the second wave of the pandemic. And as we are in the third wave, entering into the third wave of pandemic. I mean, we're not sure how the third wave will be, but a whole range of these people who are from the marginalized communities have lost their means of livelihood. So forget about having 1,500 calorie of meal per day. So there are a lot of, as ma'am also clearly mentioned, what is very disturbing is that the level of inequality in the structural and also inaccessibility to health by the marginalized people. And another very, very deeply disturbing statistics which ma'am highlighted is that there will be shortage of 18 million health workers in India by 2030, and we have only 1.3 nurses per 1,000 population and 1 doctor per 1,000 population. Now, these are worrisome trends, which we social scientists also have to really think about. And the policy suggestions and recommendations of not only the medical experts, but I think sociologists, anthropologists, economists, and so on, to the government have to be revisited by taking the perspective from below, the marginalized perspective. I strongly feel that sociologists would play a very significant role, because even in a conflict zone, even in a war zone, sociologists are always taken along with the military. And at this time of the pandemic, such as this, when we are having an invisible war with an invisible virus, I think the perspective from sociologists, economists, anthropologists are very important for the government. And it is to make sure that, the policies are inclusive and reflect from the grassroots level and not leave anyone behind. Thank you.
Thank you so much, Professor Akram, Professor Ajaylu, And Professor Tulsi Patel might want to come in, but before that, just to continue the debate a little further, may I request Dr. Papia to come in for less than 5 minutes to say something, and then we'll have two questions from Anvesha and from Dr. Nashat, and then we'll ask Dr. Tulsi Patel to come in and talk.
Uh, Thank you, Dr. Aditya, for allowing me to speak, though I was not scheduled in the speaking, but I couldn't, just sit quiet when this debate is going on, especially about mHealth and empowerment. I really like the way Professor Indira has set the wider canvas for us, which made it very clear that even for a so-called educated mass, it is difficult to understand the gender differences in perception of utilization of services and resources. And I think that kind of allowed us to start on the provocative debate of empowerment, where Professor Tulsi Patel very nicely drew the connection from the Weberian concept of power, and she linked it to the present day COVID situation. And I personally have grown up reading, ma'am, your work, and I feel anybody in social sciences who are working around reproductive and child health, the work of, and if they have not read the work of Professor Tulsi Patel, it is a must read, because that allows us to kind of conceptualize some of the very nuanced things that we take for granted. Ma'am, you so well talked about the availability of the resources, which is a chronic problem in the Indian healthcare system. And the way you brought out the importance of language as as a social determinant of health, and we have seen this when we go for field studies, that how language between the service provider and the service user is a very big challenge to kind of in the dissemination not only of services but also of information. And there, mHealth technology might be an important intervention that can allow us to kind of break the situation. And also, the ma'am, I really appreciate the way you emphasized on the training of both the service providers as well as the service users, because there is a disjuncture between these two. When we would go for field work and we ask the in our sample the women who were either pregnant or had given birth in the 3 years preceding the survey, we asked them that what is the best way that you want to get the information about maternal health. And they would say, and we gave them various options. Of course, mobile phone was another option. They said, ma'am, it is better if it is disseminated to through mobile phones. And then we asked them why. Now again, here the sociological perspective, the hierarchy within the family comes into play. They would say that most of the time when the Asha Didi, Asha has a different connotation in every state, and in Bihar we call them Asha Didi. They say when the Asha Didi visits the home, most of the time, if she has to even give the information to the pregnant woman or the new mother, but she is kind of held up in a chatting with the mother-in-law. So we have a proxy person to whom the information is being delivered. It is not getting delivered to the person for whom it is intended to. And they said that mobile phone can break this barrier. And they also said, we have many times, they are judged according to the gender norms, the gender behavior, and they are not very comfortable to discuss it in front of their in-laws or in their in the lack of privacy. And they say that if we get this information through technology, we can at least have this kind of privacy and utilize it as and when we need. So I think these are some of the things that can be kind of considered. And also, ma'am, when you talk about the importance of medical culture, how the doctors are hesitant. They don't want to, they think like, they are the demigods. They feel that they believe everything and they don't need to know anything more. So that also kind of creates an obstacle. that like stops this women from availing from the little resources or the services that we have at hand. And of course, the challenges are many, and we do need to look into this, especially how health has evolved, as you rightly point out, from a service as health as a commodity. So these challenges need to be taken care of. And you really brought up them very well. Now, coming to Professor Akram's point of views, we kind of have seen this in Bihar a lot of the times when you talk about the increasing in institutional delivery, how it is directly related to cesarean delivery, So the question comes, are we actually doing good or are we actually doing bad? It is between the choice between the devil and the deep sea. You really don't know, but that by increasing institutional deliveries, when you are increasing more of C-section deliveries, are we not actually adversely affecting the health of the women? And your point of talking about the nutrition, and especially on the medicalization of healthcare, is very well taken. We have seen this in the time of COVID, and that again points to what we would say the politics of healthcare. Like how much we have become dependent on the medical system, that we are just being driven by it. And so these are some of the very important issues that need to be looked at the ground level and are very much evident in Bihar. And Professor Ajailu, I really like the way you brought up the issue of marginalized people, especially in terms of accessibility. And I think in today's debate, we have actually covered the important pillars of public health. Professor Tulsi Patel started with the concept of availability of resources, and then Professor Ajailu concludes with the accessibility of these resources, and especially for marginalized people whom the attention is not given as much as they deserve, and also the corruption in the healthcare system. And what I like the most about your remarks, I would really say the way you brought out the role of sociologists. Many times health would be taken as something away from the social sciences to do with the medical professionals. But the COVID has taught us a lesson, irrespective of all the bad and negative things it has given up. It has brought in the forefront the importance of social sciences, especially sociologists, the perspective that society needs to change, the attitude of the people needs to change towards health, and we have learned to realize that health is an asset, and we should try to promote it and preserve it. Now, I think I have exhausted my time limit, so I would stop here and give it back to Dr. Aditya. Thank you.
Thank you, Dr. Papia. Now, can we take two questions and then Professor Tulsi Patel will come in and, talk about some of the things that she wished to bring in as part of the discussions. Can we ask Anvesha, please? Anvesha is a PhD student. She wrote in the chat. Anvesha, can you come in? You can unmute yourself.
Yes, sir.
Go ahead.
Uh, Greetings to one and all. I express my sincere gratitude for such an enlightening lecture and for giving me this opportunity to participate in it. I would like to ask regarding the delineation of stratified job opportunities in healthcare informatics. How India can proceed towards creating dedicated employment opportunities in this regard. And secondly, how we can inculcate the importance of public health in youth. Ma'am, that is all.
Okay, thank you. Dr. Nuzhat, can you come in and put your question so that, we take all of these together? Very good question, Anvesha. Dr. Nuzhat,
Yes, sir.
please.
First of all, I would like to extend my gratitude to the panel for such insightful lecture. And with due respect of the dignitaries, I would like to put forward my question. On the one hand, we are talking about health empowerment from the gendered angle or gendered perspective. And on the other, we are witnessing the sheer infantilization or dematuration of women, which is a kind of wrongful concealment of their unique identities and their related problems by clinging child to women. limiting women's health to reproductive health only since ages. What comments you have over this for us, ma'am?
Thank you. So, Tulsi ma'am, you can unmute, and you had so many things come in from the discussions, and Papia came in, and these two questions. If there is any other question, please keep it. We'll
So,
see if we have time.
sorry for intervening. Can I just take
Yeah,
a
please,
second
please.
to ask Professor Tulsi Patel? It's not a question. I just read that there is a gender bias in COVID-19 vaccinations delivery. What do you say about that? I just read it. Thank you. Sorry for.
No, no, it's a very good question. Sorry. So, ma'am, over to you, Tulsi ma'am.
Thank you for all the comments and observations made. Some of them were actually information to me. So I'm thankful for that to Professor Akram and Professor Jailu. And a very good way in which Papia mentioned about some of the issues I'd raised. I never thought they were that relevant. Thank you for the comments. When I talk of the ethics issues, uh, I think the issue of cesarean sections and the issue of hysterectomies are two major issues as far as women's health is concerned with institutionalization. And just as you mentioned that COVID 19 has taught us that nutrition is important, and so is natural remedies or herbs at home. So the homemade kada is important. And that's what has actually saved a lot of people who did not have to go to hospital. It is important. But what is very surprising is that my work with midwives in Germany or with sporadic interviews with medical experts in other countries of the world and some obstetricians in India as well who are not part of the mainstream obstetricians but they stand out as very different is that obstetricians who conduct more cesarean sections and hysterectomies without requirement are of one type who look at health very differently than obstetricians and midwives who look at health completely in an opposite sense, where the idea of natural birth, the idea of warm water birth, the idea of scotting and bringing birth, etc., are important for midwives. And what is very striking, and I was very surprised, is that in Germany, if you are being trained as a medical doctor, you need a lower percentage to qualify for admission than if you were being trained as a midwife. So it becomes more and more difficult for a person to become a midwife than to become a doctor. And because we think midwives are guys who are illiterate and they don't know anything about the body and birthing, so we it is for me it was a very striking cultural shock of a kind or a cultural contrast to see that in Germany you need to be a better student to get into midwifery, and midwifery is not covered under health insurance. So the role of the state and the market in what is being provided and what is available is also a very serious policy issue in terms of both finance, commitment of the state, and what market is available, and how the state and the pharmaceutical market come together in terms of framing policies for health. So even the Ayush doctors who sit in PHCs, whether they are allopaths or homeopaths, they also prescribe allopathic medicine because that is the medicine that is usually available. So we need to look at those policies also. The idea of nutrition and home care is very well taken, Professor Akram. And also the importance of the alma mater declaration or the way PHCs work in different places. Yes, certainly, if you look at state differences and look at small studies, that would be a big contribution to make even for mHealth and empowerment. Professor Ajailu's comments, I really, really appreciate the information she gives about how people are suffering due to shortage of food in remote areas. What to think of having a smartphone or using mHealth. It's something beyond. Survival is more important. So between survival and using health, accessing health and accessing mHealth, there are various steps that they need to cover and the importance of the state to do that. Dr. Papia's comments were mostly in terms of appreciation. So I take that her idea of what women want, what pregnant women want when people go to the field for research is something that is very well taken. I appreciate that a lot, and that must go on to tell that gender disparities exist by age and relationship as well. So the same woman who is a daughter-in-law at a stage when she becomes a mother-in-law may not have similarity of interests. The interests might clash or vary. Now, the question raised by Anvesha on stratified opportunities for health workers or a dedicated possibility, I think the manner in which the state is recruiting, whether it is in the field of education, universities, schools, or health, since the liberalization of the economy, health and education, which have been the major areas of a welfare state, have taken a backseat as far as India is concerned. So it is for several years now that health budgets are being affected and education budgets are being affected adversely by the state. To think of sociologists and to think of dedicated positions in health sector where social scientists could come in. I have experienced that there are some hospitals where the position of a social worker is there. And I'm surprised how policies allowed that. I personally think at the expense of sociologists because social scientists in general would hesitate to intervene as quickly as social workers would intervene. To be able to care for what people want and what can be provided and negotiate in that through the understanding of cultural differences can be done far, far better by a sociologist. But I think policies have been framed in such a way that wherever you have this intervention or a possibility of a position, it's being taken by social work. I have nothing against social work in general, but at least as far as theoretically I'm concerned, the sociology student is far more aware of cultures, cultural variations, gender variations, and theoretically it is important to be able to know the problem, know the culture and cultural and social problems rather than to be able to decide for intervention immediately and not question policy. A sociologist would be trained to become a little critical of the mind in the mind of what is being offered and what is being desired and compare that. So that's my personal view, and I don't think sociologists are very important in policy decisions and we can make a big thing. But Anvesha, if you ever happen to be in government, please keep that in mind. Nuzat Sayed on women's empowerment and infantilizing, I fully agree with you. Most of our health budget has gone to mother and child health, and in the name of the mother and child health, it has been fertility control. Primarily controlling the number of children women are bearing, and the manner in which this happened after 1994, it became mellowed down. When men were controlled for fertility in 1975 and 76, governments fell down. Indira Gandhi lost terribly badly. So population and fertility are very, very critical for human society. And if you touch men, you had it. women are really infantilized as far as that is concerned. So it's far more than the fever case, but it is serious and it is an extension of the fever example. Thank you, Professor Indira, for that. And your comment on COVID 19 for vaccination and gender relation is equally valid when we look at the gender differences in that. In areas where there was vaccine hesitancy, it was women were proposed to go in for vaccination, and where there was no vaccine hesitancy, it was men who preferred to go in for vaccination. So, like your fever example, vaccination is vaccination, but depends on how it is understood. And then, according to that understanding, it goes to men or women.
So thank you, ma'am. The two, Priyanka wants to come in and ask a question, and then Anand. Priyanka, it's over to you. Put your questions, be brief, and then Anand, you can come in.
Thank you, Professor Mohammad Akram, and a very good evening to the panelists. It was really interesting to listen to such a very relevant topic. My question somehow is not directly related to the address given by the panelists, but this is a concern which has been there since I've been reading on this area. So, since artificial intelligence and digitization and technology is coming, and Japan is a very good example in this case, in terms of intersecting with healthcare and technology, both are intersecting to provide the services. But my question is how we are conceptualizing healthcare here, because health itself is not the absence of disease, but it's general well-being. So in terms of the healthcare or tools like robots or smart watches or monitoring, I think in India, particularly, health is understood as more of a physiological manifestation. But what about emotional health, mental health? We have high rate of suicides, we have chronic constipation, we have dementia among elderly. So my question is, in designing these tools for the future, where we are talking about AI and healthcare, the data that we have, I think it's one on the one hand biased. Second, there is a problem in the conceptualization because, for example, in the one-stop crisis centers, women in crisis, we don't think that women who are under emotional disturbance are actually facing health problem. It has to have physiological manifestation. So I just want a comment from the experts on this perspective. Thank you very much.
Thank you, Priyanka. Can you come in, Anand?
Yes, Aditya, thank you so much for such a powerful, great start. I'm really overwhelmed with the kind of speakers and the way you have organized it. I congratulate the organizers, and I'm really thankful for the presenters and keynote and the sessions and the discussants who have really enlightened us. My simple question is like the nexus between pharmaceutical industry and the disease as such. This is, I'm not talking about CDC, I'm talking about disease control in India. What kind of nexus do they have so that like these patents and royalties are making even in India, a socialist mixed economy in India, we have too much of hike in the most essential medicines. How healthcare policy can take care of this? I just want reflections. Thank you, Aditya and Papia.
Thank you.
Okay. May I take these questions?
Yeah, ma'am, please.
Yes.
Please.
On the digitalization and artificial intelligence enabled mHealth conception, it's an interesting question because it raises the issue of conceptualization itself, how the idea is conceived. The idea is conceived very much in terms of inequalities and disproportionate access to these health inequalities. So, while the WHO defines spiritual and social well being as part of health, uh, we do not see that as the logic for mHealth here. But mHealth, in terms of not mobile health here, but in terms of mental health, is now emerging in India as a very serious issue. And it also has some cultural inhibitions towards accepting mental health in our culture. So while we have accepted the idea of health and illness at the physical level, the idea of mental illness is something which is still unacceptable and is something which is still wrapped in covers. And that's reflected in the policy as well. And emotional issues and gender is something which there's a lot of literature available on who cares for women. They can look after themselves. They need to be. There's no need to be bothered about them. But what I also observe, if you look at the small, maybe tribal, even peasant, non-tribal, but small communities and societies, there are a lot of social institutions that enable women to deal with their emotions. Whether these are through festival celebrations, through visits to friends, through visits to parental homes for a longer duration. There's a range of things that women can do, and they're allowed to do that interval or that slot, which is all women's area, whether it is dancing or singing or performances, rituals. There are a lot of possibilities of women sharing problems, and emotional care is in a direct or indirect way provided there. But with more and more of education and urbanization, there is a greater isolation as far as gender is concerned. So, gender and emotions become more serious problems, and so do mental problems and health. So, that's a very valid point. And I think maybe one of the that on Anand's question, this nexus between pharmaceuticals and pricing, it's it's something which is now for more than 20 years part of India, and it is the industrialists who actually rule the roost. So to think of a pharmaceutical industry which is going to be a non-profit and do a kind of social service rather than earning a profit is something we can't think of. But in states like Rajasthan, government provides generic medicines to all patients who are below the poverty line, who can't afford to take medicines. To a great extent, free medicines are provided. So while there is this nexus between the pharmaceuticals and the industrialists at the policy level as well, and pricing doesn't come down, through the practice of generic medication, where doctors all over India in some way have been pressured to provide generic prescriptions. Some bit of denting might be there, but the industrial lobby is very, very strong in whether these are democracies or not democracies. It is very, very difficult to think of that bonding to be breaking in favor of common masses.
Thank you, ma'am. Thank you so much, ma'am. I was hesitant to give your number to Dr. Papia, but she was insistent. I told her Tulsi ma'am is not keeping well, so you have her books. But she was hesitant. Let's bring her in. So thank you so much. So we can continue talking about this. Professor Akram, you thank you for your time. Uh, Professor Indira, Ajaylu, all the participants. We are so overwhelmed. We will continue this discussion further. I would like to bring in Papia for a formal vote of thanks. And before that, I want to say, Akram sir, do you want to come in? Please.
Yeah. A small point I want to make. There are
Sure.
so many things that we can talk about, but a small point is this, that Professor Indra has started talking about this female fever or male fever, and then this was appearing time and again. And let me just very briefly talk about it. Basically, feminization of medicine is a very important area as of today. And see, we have been talking about clinical trials, but are we aware of the total number of women participants in these clinical trials? Is anybody aware of this? So basically, I went through a book that is a feminist medicine, and I was amazed that is it like is it a narrative like that female fever or male fever? But the core arguments are there. The arguments say that whenever we go for a clinical trial of a particular medicine or injection, then most of the time the volunteers are actually the males. We never get to know the gender composition of the volunteers. So basically,
So important. So important.
what is happening is this, that even if we go for trials of those medicines, but we will never know how do those medicine actually impact upon the female bodies. And we know that the females do have different hormones at different stage of their life. So basically the medicines are actually neutral, blind to the female bodies, and here we need a huge intervention. The medicines are actually blind to the female specific characteristics. We need a huge intervention. So this feminization of medicine and then female epistemology are very much required. Then the narratives, basically the narrative medicine that we are talking about, where do we have the female presence in the medical narratives? So basically, we have not started to look at the issues related to healthcare and medical from the feminist perspective. And then one more thing that I would like to talk about. Basically, there are issues related to state sponsorship of the health. See, India has not been achieving major things in terms of health, right? We started with the idea of health policy in 1983. We are a very slow starter. So whatever we have achieved as of today, we are talking about that. But we all understand that we have not achieved the kind of thing that we are supposed to achieve. There is gross inadequacy, right? Now somebody was asking a question related to how can we ensure nutrition among the poor people, right? This was a question in the chat. Basically, we need to understand that we are a welfare state, and in a welfare state, all these core needs should be taken care of by the state. It is the responsibility of the state to ensure food for all, to ensure health for all. These are there in the directive principles. How many among us are aware of the fact that the health issues are the core issues in the directive principle? Have we ever talked about that? Have we ever discussed that the health right should be a fundamental right for every citizen of the country? Unless we go with that kind of narrative, we are not going to talk about development or health in a right perspective, right? So that is my summary of the whole argument, that we need to talk about right to health, we need to talk about healthcare, we need to talk about food, we need to talk about water. These are the core ideas.
Thank you. Thank you, Professor Akram. We can continue to talk about this, but constraint of time.
Right.
But very important points. Some of the issues that, for instance, Priyanka raised about mental, emotional health, those are important too. And I think during COVID, we realized the importance of mental health so much, so much. So, I mean, I just want to say before I give it to Papia for a verbal vote of thanks that next week, Saturday, we are going to explore health concerns in colonial India. The slide is set by our technical team, Devna Srivastava. Professor Deepak Kumar, our teacher in JNU, will be talking, and his work on history of science and education is well known. It will be good to see the trajectory, and we have Professor Ashok Ghosh, the chairman of Bihar Pollution Control Board, come in as for inaugural note. And then we have two discussions. One is a clinical practitioner from Nottingham, originally from Patna, Salini Ocha, and the other is Manish Bhardwaj, a MIT graduate in electrical engineering, now at Princeton, but involved through an NGO in doing a lot of developmental work in Bihar for tuberculosis and other things in Samastipur districts. So this is just an advertisement for next week. Please join in. Continuing the discussion will be good. And I want to leave with just a note that Navratras are going on. Happy Navratras to everybody. May Lord Durga bless us all, shower blessings and kill the demon within us. And I think it's not possible for any change to anticipate without placing women at the center of things. So let's place women at the center of things and think through all problems that we have. That's it from me. Dr. Pabia comes in for a formal vote of thanks. Thank you very much.
So I propose a formal vote of thanks. First of all, I would like to thank ICSSR-IMPRESS for their general funding that allowed us to conduct this kind of interactive session and have such a powerful discussion. I'd also like to extend a sincere thanks to Professor Indira for accepting our invitation despite her busy schedule and being on time. She was there at 7:30. In fact, quite a few minutes before that, and that allowed us to start the program on time. Professor Tulsi Patel, I cannot thank you enough, ma'am. Despite all your commitments, you agreed and you enlightened us with your thought-provoking perceptions about healthcare, especially about reproductive and maternal health and the challenges we face. Professor Akram, again, a special thanks to you for joining us and sharing your viewpoints, especially in this with in the connection to the state of Bihar. Your work in areas of health and sanitation are really remarkable. And today, thank you for sharing your thoughts with us. Professor Ajay Lu, who I cannot really thank enough. Ajay is always there. She never says no. And thank you again, for being there, for accepting our invitation and also enlightening us with some of the issues that we at times forget and we take it for granted. For example, talking about the importance and the role of sociologists in our day-to-day activities and in important matters that needs a lot of concern and care. Thank you, Professor Ajay. And I would also like to extend my thanks to the R&D department of IIT Patna, who allowed the smooth transaction of the paperwork. Our PhD students who had been very enthusiastic and on their toes to help us out all the time. I'd also like to thank our technical team with Sajal and his teammates, which made this smooth streaming of this event live on YouTube. Thank you, Sajal. And I would also like to thank the participants, without whom such events are not meaningful. And last but not the least, I'd like to extend my sincere thanks to Dr. Aditya, my spouse and faculty colleague, and my partner in life as well as in profession. I don't think without his support and encouragement, I would have been able to do this smoothly. So once again, thank you all for participating, and we look forward to more such events and more interactive sessions. Thank you for joining.
Thank you, Dr. Papia, Dr. Aditya, and everybody, and to Professor Tulsi Patel. Thank you. Bye, Ajay.
Thank you, all of you. Thank you all. Ajay,
It was nice to see Professor Indra and Professor Tulsi Patel. Love to see all of you. Thank you.
Nice to
Thank
see
you,
you.
Dr. Aditya and Papia and Professor Ajay. Thank you very much.
Okay.
Pleasure is always ours.
Bye now.
Okay. Bye-bye. Good night.
Bye. Good night. Good night.
Thank you.